but that it's not going to change their risk either way of getting breast cancer in the future.
We can do things to the breast tissue, but technically with breast lift, we're really not removing breast tissue.
That's not going to change much to the shape of the breast itself, but it will lift the nipple very, very conservatively.
If you are really not able to lactate, produce milk pretty well before surgery, a breast lift may not help things.
The beauty scientists, Dr. Kristy Hamilton and Dr. Roy Kim. Real beauty without the hype.
Hi, this is Dr. Roy Kim, co-host of The Beauty Scientist, and I'm joined by Dr. Kristy Hamilton. How are you?
Great. So good to be here, and I'm excited about our topic today.
So we'll be talking about breast lift and specifically aims more at aesthetic breast lift. So, of course, things can change after gravity, after time, after pregnancy, after breastfeeding. So, Dr. Hamilton, what or who are the best candidates in terms of breast lift, and what are you really looking for?
So the ideal candidate for a breast lift is someone who is seeking a rejuvenated, higher, tighter shape to the breast, and we're restoring it back to how it originally was. This is also not someone who's looking for more or less volume. This is someone who wants essentially the same amount of breast that they have, just placed higher and tighter on the chest. So life happens, changes happen. Many women experience pregnancy, breastfeeding, weight gain, and then weight loss. And all of those can lead to ballooning of the breast and then later their deflation. And so it's essentially a restorative surgery. It's turning back the clock and helping to reset back to the way the breast used to be.
And so one of the myths, I think, which we can talk about is, okay, you have an actual breast lift procedure. In terms of the myths, I think patients often ask me, will something happen to the nipple? So specifically, nipple sensation, ability to lactate or produce milk. What do you say to patients when they ask those questions?
That's a great question, especially because there are a number of patients that have the surgery before they are considering starting families. So the vast majority of women after undergoing a breast lift are able to go ahead and breastfeed. There's a certain percentage of women, regardless of whether they have surgery, that struggle to breastfeed when trying. And so what I tell patients is just because you had surgery, you could still be one of those patients. But when you look at the percentages, and we have studies to back this up, we know that having a breast lift does not decrease your ability in most cases to breastfeed. Now, sensation, I think you can speak to this too. I tell patients you can expect the sensation at first to be a little bit decreased. At the end, it should end back to near normal, but some patients will experience reduced sensation, rarely absent sensation. Some patients will even have a little bit of hypersensitivity or more sensation afterwards, but most patients can go on to breastfeed. What's your experience?
I totally agree with you. I think it really depends on the procedure, but in general, breast lift procedures, you should be able to lactate or produce milk long term, as well as have normal nipple sensation. My understanding of anatomy as well as physiology is if you are really not able to lactate, produce milk pretty well before surgery, a breast lift may not help things, but that's simply the way that your anatomy is in terms of your own body, and a breast lift really doesn't change much.
Yes, there's causation versus correlation, right? So just because those two things happen to come together didn't mean that one caused the other one.
Right.
So you can safely get your breast lift if you want to have kids in the future.
I think so. And then also the nice thing is that in case an accident happens, in case you want to have more kids, yes, you should still be able to lactate or produce milk. You should still be able to have nipple sensation long term. In terms of, let's see, now this is the nerd talk, because what is a breast lift as opposed to a breast augmentation?
Great question. And so one of the key factors we want to decide when you're sitting down and discussing aesthetic breast surgery, what are your goals? If an increase in volume is one of them, then you can still have the breast lift to restore the shape, but you're going to have to consider other additional surgeries at the same time, other components of the surgery, like adding an implant or fat transfer. A lift alone is going to, not only is it not going to add any volume, but I tell patients that many of them will feel like they need to go about half a cup size down in their bras, not because breast tissue was removed, but just because everything is origami together so that it's higher, tighter, and more compact. So if that doesn't sound appealing, then you need to consider adding a small implant or fat.
And yes, underneath the surface, we can reposition breast tissue. And I always tell patients it's important to realize we can do things to the breast tissue, but technically with breast lift, we're really not removing breast tissue. We are repositioning it and we're removing loose breast skin and tightening it up. I think that's very important for patients out there to know in terms of pathology of the breast, breast tissue, breast cancer surveillance, and all those good things. What do you tell patients?
I tell patients that if they are over 35 or older, I like them to get a preoperative mammogram for screening purposes, but that it's not going to change their risk either way of getting breast cancer in the future. Occasionally we catch some early cancers with that preoperative mammogram. So if anything, considering a left may actually catch something in advance, but that's not the reason to have surgery, of course. And again, I tell patients to think about it as like an origami of their breast, right? So we're working exactly with the tissues that they already have, but we're rearranging them for a more aesthetic, ultimate look. And that's what's going to change. And specifically the position of the nipple on the breast. So we make the areola smaller. Oftentimes after the breast getting larger and smaller, the areolas have expanded to a size that's larger than they originally were. So we make them shrink down to size. I like to do about 38 millimeters or so across, just depending on the proportions of the patient. And then we position them exactly in the center of the breast. And at first, I tell patients afterwards, you're going to look like you've got small implants. We make everything so high and tight that there's a lot of fullness at the top of the breast and the top of the chest, but it will ultimately come down to a natural teardrop shape. So if that's the aesthetic that you're looking for, a very natural look, great. If you like that more cleavage look, then again, you're probably looking at getting a lift as well as an implant to get that look. So I think that's an important distinction, that kind of convex upper pull of the breast versus that teardrop, slightly concave look. That's what you're going to get with a breast lift.
I often tell my patients, look, if you feel in terms of volume, your breasts are a little too big, breast lift is a great operation because you're going to lose some of that fullness. You're going to have a more aesthetically pleasing breast, and you probably don't need an implant. However, the patients where they want a certain shape, they don't like the slope at the upper pole of the breast. If they already feel they're a touch too small and they want to go even bigger in terms of volume, then I mean, you need, some type of implant technology, whether it's fat or implant, to actually get you those long-term results. What do you counsel patients when, they get a breast lift and they only get a breast lift? What do you tell them in terms of like loss of volume or cup size after a pure breast lift only?
I tell them after a pure breast lift only to expect about going down about half a cup size in their bra. And again, I make the distinction. We're not removing breast tissue with this operation, but it's just the way that the tissues are now sitting on your breast because we've rearranged them to be more compact. So everything's tighter. And for that reason, they may go down half a cup size in their bras. And so that's a good distinction to know. Like, are you okay looking a little bit smaller than you currently are? Because that's likely how you're going to feel afterwards.
Yeah, that's what we always tell patients. And as you know, Dr. Hamilton, there are 4 major different types of breast incisions to the outside world. And then there are like sort of 4 major procedures. Crescent incision, periareolar, which is a fancy term for just an incision around the areola, or also known as a Benelli mastopexy. Vertical mastopexy, vertical breast lift, and an inverted T incision or anchor incision, where the incision sort of looks like an anchor or T. I think the easiest one and not commonly done is the crescent. I don't know how often you do that or the ideal candidate.
The crescent, so that's taking exactly what it sounds like. It's like a little crescent of skin along the border of the areola at the top and then just pinching the areola up. So that's not going to change much to the shape of the breast itself, but it will lift the nipple very, very conservatively. This is not something I do for patients. I think to me, this is more of like a revisional. If you're seeing a patient and you see, oh, one nipple is a little bit lower than the other one, maybe we can do like a little crescent to help even that out. But that's not going to end up being a very powerful lift. And I think in terms of the order that you were mentioning them, the first 2 and the second one, the Benelli that you were talking about, where they go all the way around the nipple and shrink it, that has the side effect of flattening a natural breast. So unless you're putting an implant in there too to create that nice round shape, that it's also called colloquially the donut breast lift. I think that works reasonably well for patients having implants placed that needs 1.5 centimeters of lift. But otherwise, you're looking at the vertical or that anchor pattern incision to really get a more powerful lift. And whether you need the scar in the fold as well as the vertical ones depends on how much excess skin you have in the vertical as well as the horizontal dimensions. And that's something that you and I walk patients through when they come in, and we can demonstrate on the tissues why one might be the most appropriate. But most commonly, when I see patients that want to seek surgery, I'm doing the inverted T or the anchor pattern.
Yeah, same in my practice. I think probably the same generally. In my hands, the Benelli mastopexy, the donut mastopexy, in other words, only an incision around the areola. I can only lift it about an inch or a little less, and most patients need a little more lift. And you're totally correct about the overall shape. It has to be the right patient, otherwise it tends to be flattened. The vertical mastopexy, of course, I love calling it the lollipop incision, and that's how a lot of patients know about it. That is a great option. And the inverted T is also a very good option if you need a lot of lift. Now, that's on the outside. Internally, yes, we're tightening up breast tissue, as you said, sort of like an origami pattern. But there's newer technology, including the internal bra. I don't know what preferences you have in terms of the tech as well as the ideal patient.
So the internal bra, that's really become popularized on social media lately. And I think it's even calling it that, the internal bra, it's a great concept, right? Most women would love to not have to wear a bra, but really appreciate the support that it provides, especially if you have larger breasts. So this concept of having something on the inside that's providing support, I think is very appealing to patients. And then as a surgeon, I think it's a great innovation because the durability of the result, obviously, like you and I have to create an excellent surgery and do a technically great operation, beautiful suturing, excellent scar care afterwards on the patient's end, follow all the instructions. But at the end of the day, there are factors that we can't control. And namely, the main thing is the quality of the breast tissue itself. And one of the issues is that some people, just especially as time goes on, just their genetics, if they were like smokers or whatnot at some point, is they end up with or patients who have stretch marks on their breasts because of pregnancy and breastfeeding, their tissues are just not as great as they used to be. And that's one of the reasons why they found themselves wanting to have a lift in the first place. And so for some of those patients, you can do a beautiful operation, they can do everything right. And then a year later, they find that things are already starting to go south again in terms of the position of the breasts on the chest, and the nipples are starting to go down. And so if there's anything that we can do to kind of like an insurance policy for their surgical result, anything that's going to help give more support and prevent that droopiness from recurring as quickly, I think that merits a conversation. So I always bring it up with patients. I don't think every patient needs to have one, and not every patient wants to have one, but a lot of patients are excited by that idea. And if they find themselves being the ones that have more of that looseness to their tissues, I think it's a great option. How often, what percentage of patients do you think you're using the internal bra for in your practice?
Something where I'm using barb sutures, using internal tissue to create sort of patient tissue bra, like every single case. Now, in terms of using non-autogenous tissue, fancy medical term for man-made material, I would estimate probably about a third of my cases, because cost is an issue as well as what the patient desires. And there are a couple options of materials, but I definitely strongly prefer something that is not a cellular dermal matrix for my breast cases. I don't know what your preferences are.
Yes, because we found those were too stretchy. And so that was an issue. Also, incredibly expensive,
Yes.
prohibitively expensive for most people. So all of us have been using, or the vast majority of us have been using these materials that slowly degrade over 6 to 18 months and ultimately transform into a thin sheet of scar tissue or collagen. And we place it along the lower pole of the breast. So that's perfect. That's exactly where like the cup of your bra would be. Then there's a new material that's just come out that people are starting to use. I haven't used it yet, but that's kind of a blend of some of the benefits of having the degrading one, and they're using sheep's gut, I believe, as the biologic material. And they're pricing it similar to the PDS and BH4B meshes that we've been using. So they're trying to break into the cosmetic market. So we'll see how that goes.
Just for a rough cost analysis, because it's hard to say depending on your region and country, the acellular dermal matrix is very expensive. We're talking several $1,000s additional on top of whatever surgical fee. And obviously that's literally the wholesale cost of just using that material.
Yeah. And that's per side.
Yes.
That's just for one piece.
That's correct. And then that plus the stretching, the newer ones don't stretch. So once it's inset, we know the exact position of your breast fold because it's not moving. Whereas the ones that are sort of stretchy, the acellular dermal matrix, unfortunately, we're talking 6 or 12 or 18 months down the road, the breast fold actual placement may be a little off because the internal bra, unfortunately, has stretched out. So that's...
So we like these other ones.
Yes.
We like the stiffness of them. And so even for this hybrid one they were talking to me about, they were like, okay, the benefit of the biologic of the tissue integration, which we know, so it kind of incorporates perhaps a little bit better, although the synthetic ones incorporate really, really well too. But they recognize that we are liking the stiffness and the reliability of the synthetic materials. And so they made sure they kind of incorporated that. So I was like, that's interesting.
Yeah. And so in terms of the patients, what do you tell the patients to get ready for the actual operation and then the technique of closure and finally sort of the recovery?
I think this is a fairly easy recovery. I think it's one of the easier recoveries as far as like breast and body work, bigger cases. Breast surgery, it's not particularly painful. Patients are feeling pretty good right afterwards. If you have a desk job, I think you can get back to work just after the weekend. You'll slow down your activity levels a little bit just because you've got the incisions. But once those have solidified, you get back to your regular life pretty fast. In terms of preparing, again, I think it's one of the surgeries that's easier to prepare for. We just want healthy living, of course, absolutely no smoking, just like usual. Run your supplements by your surgeon to make sure you're not taking anything that you need to stop. But other than that, I don't think there's so much preparation. Timing after having kids and pregnancy and breastfeeding is something to consider. So I like patients to have not been breastfeeding for at least 3 months afterwards, because it takes a while for all that residual milk and the milk production to shut down. And we want to make sure that we're not cutting into actively lactating tissue while we're doing your surgery to decrease the risk of infection.
Yeah. One of the things I always tell my patients is that the T incision, or 3 areas of skin being brought together, potentially is going to have slower healing. If you think about it, most incisions are like literally just 2 sides. You have a cut, you fix both sides. With the areola, as well as the vertical incision, or the vertical incision with a horizontal incision, now you're talking about 3 pieces of tissue. And I don't know about you, but the annoying T-zone has always been an issue. But I think that's true for all plastic surgeons. And the reason is blood flow.
It is slower to heal, and it's the tightest spot of the whole thing. And so we know tension slows down healing as well. And so I tell patients too that that's something that you may experience, and there's a reasonably high chance that you'll experience that part of the scar slower to heal. And so just to prepare for it, and everything's going to be great and look wonderful. Just may take a little bit more time than the rest of the breast.
Yeah. And typically these procedures are done on an outpatient basis. And usually, I'm sure you do as well, but most plastic surgeons now are using sort of the local numbing medicine given at the end of the operation. Patient's still asleep. We're giving you lots of numbing medicine. And the stuff that we use today lasts for 72 hours. So this really reduces the amount of pain you feel, and you can definitely take fewer pills, which can make you queasy, nauseated out of it. And this is where Dr. Hamilton said, hey, get this done right before the weekend, and you can probably go back to an office job by Monday or Tuesday. And that's been the experience of my patients as well.
And that's great. And so, because that's always a major concern with patients is like, okay, I want to have this, I'm ready for the look, but I'm scared. And so it's really important to make sure that patient comfort is a priority, and that's because we want it to be a good experience. It's aesthetic surgery, something that you want to do. It's not something that you need to do, and so we want to make sure that you're getting back to your normal life as quickly as possible.
Yeah. Now, in terms of recovery, of course, most of the healing will occur in the first month or two. Most of the swelling goes down in the first month or two. To me, one of the bigger things that patients always discuss is the potential vertical incision. Anatomically, there's no vertical incision on the breast, and they're very worried about it. Do you have any hints about how to really get that scar to look as nice as possible?
Yeah, so on our end, we need meticulous technique, perfect positioning of those tissue edges together, and a great suturing technique. So we'll handle that as the board certified plastic surgeons that we are. And then on the patient's end, you have to wear your post-op bra. We want to help take off the tension off the healing breast incisions. And then I implement after the steri strips come off in 2 weeks, I implement a silicone tape protocol or gel for those who can't tolerate adhesives. And we do that for as long as the patients can stand, at least 4 months afterwards. So that's been clinically proven to help with scar tissue formation. And then we're watching them closely. If we see signs of more scar tissue forming than we want, we may do a series of injections. So that is a very important part of the healing process, and we can do laser treatments down the line. There's all sorts of different options, just depending on the patient's like skin tone type and what type of scars that they're forming.
Yeah. Ideally, it's going to heal up great. We are plastic surgeons. It typically looks great right after surgery, but it has to heal up. And as the new skin grows, it will continue to be non-red, non-wide, non-thick, and will continue to fade over time. But if it doesn't happen, there are a lot of non-surgical options within the first 6-12 months after your procedure. I always, tell my patients that if you tell me about it, I'm not going to see you every week, but if I see you once in a while or you let me know, there are non-surgical ways to make this look better. If you get the procedure and you disappear and I see you 3 years down the road, not much I can do except cut out the edges of the scar and start all over again.
You definitely want to attack, if there's an issue that's forming, you want to attack it early so that you can get a handle on extra scar tissue formation and whatnot. And then I think one of the things that patients ask about a lot is just like the pigment or like the color of the scar. And so we know like the pinkness or the purpley redness of a fresh incision, that always fades. So as long as the scar itself is thin and fine, I tell patients, like, don't worry about redness in the incision. It does take the better part of a year for a scar to fully mature. And so that part, while the shape and the swelling and all of that's been established earlier on, you do have to wait longer to have the scars fade. And that's just part of the process for any scar.
Yes. And of course, a big question my patients always ask me as well is, okay, we do a breast lift. How long is it going to last? And I always tell them, depends on how you maintain it, depends on your metabolism, depends on how loose your skin was to begin with. It's not really measurable, but the reason why you needed a breast lift in the first place is lack skin. So any hints on how to maintain the results?
So continue wearing your bra all the time, except on Saturday night if the dress calls for it. But you want to maintain as much support as you can, maintain a healthy lifestyle and diet. So that's really important. It's never too late to start that, and you'll see improvements also in the skin across your body, on your face as well. But you're right that there is a genetic component, and there's also the reality of just like how your tissues are, and if you are someone who has stretch marks already, so there's a certain amount of damage that's been done that can't be undone. But you can always make improvements just by diet, exercise, taking good care of yourself, and wearing your bra. What do you tell patients?
I tell them essentially the same thing, because so many patients don't really want to wear a bra, but I do tell them the more you support it, we think that the better your long-term result will be. This is why it's so important to have an internal bra as well as an external one. And that's what I always tell my patients.
I think more is more when it comes to support.
Yes. And so any final thoughts or questions, Dr. Hamilton?
I think we about covered it. This is probably worth mentioning that this past year, when the American Society of Plastic Surgeons looked at the data, this is the first year that breast lift popped onto the top 5 aesthetic procedures for the year. So it's a hot topic, and it's a hot surgery something that people are definitely more and more interested in. So I was happy to talk about it with you today.
I think it's going to become even more and more popular.
I do too.
Yeah. Well, on that note, thanks as always for joining me, Kristy, and to all the listeners and viewers out there, thanks for joining us. If you have any topics you want us to discuss, please fire away below or let us know. And as always, stay beautiful.
Stay beautiful.
Thank you for joining us on The Beauty Scientists. Be sure to visit thebeautyscientists.com and learn more about modern beauty and connect with Dr. Hamilton and Dr. Kim.